Hi everyone, my name is Faustine Ramirez and I'm a master tutor with MedSchoolCoach, and today we'll be reviewing a Step 2 CK question. So let's start by reading the stem. A 78-year-old man presents to the emergency department with 3 days of worsening confusion, fatigue, weakness, and shortness of breath. He also complains of abdominal pain, nausea, and decreased appetite and has lost 4 pounds since his previous admission. On review of systems, he endorses dizziness and visual disturbances, including blurry vision and yellow discoloration of objects around him. He has a history of congestive heart failure, hypertension, atrial fibrillation, and coronary artery disease. His medications include warfarin, furosemide, enalapril, propranolol, digoxin, aspirin, and amiodarone, which he recently started. Upon arrival, his temperature is 37.5 Celsius, heart rate is 118, respiratory rate is 20, blood pressure is 152/83. He appears anxious and confused. He is oriented to person, place, and time, a person and place, but not to time. Pupils are 3 millimeters and reactive to light. Neurologic exam is otherwise unremarkable. Respirations are mildly labored. No murmurs are auscultated. Radial pulses are strong and rapid. Electrocardiogram reveals atrial tachycardia with 2:1 AV block. What is a most likely explanation for these findings? I'd like you to pause the video now and try to work through this question on your own first. All right, so welcome back. So let's approach this question together. The first step is going to be to read the actual question itself, the very last sentence of the stem. What is the most likely explanation for these findings? So this is going to be a question about a diagnosis or an underlying cause or etiology. It's not going to be a management question. And we briefly glance at the answer choices and we see that they fall into multiple categories, either medication toxicities or underlying conditions or exacerbations of underlying conditions. And so we'll have to keep an open mind and think broadly as we read this question stem, because the answer choices are not giving us a clue about what bucket to be thinking about. We have to think broadly. So let's read from the top and highlight the key elements. A 78-year-old man presents to the emergency department with 3 days of worsening confusion, fatigue, weakness, and shortness of breath. He also complains of abdominal pain, nausea, and decreased appetite, and has lost 4 pounds since his previous admission. On review of systems, he endorses dizziness and visual disturbances, including blurry vision and yellow discoloration of objects around him. He has a history of congestive heart failure, hypertension, atrial fibrillation, and coronary artery disease. His medications include warfarin, furosemide, enalapril, propranolol, digoxin, aspirin, and amiodarone, which he recently started. So when we're reading these long question stems with an exhaustive list of medical conditions and medications, it's really important to pay close attention to these, because often your eyes kind of start to gloss over when the patient has more than 1 or 2 medical conditions or medications, and you kind of skip ahead to the next part, and that's on purpose. That's there to try to distract you, to try to trick you into reading too quickly. So when these patients have these long lists of medical conditions and medications, really pay close attention to them, because it might be important in order to answer the question. Upon arrival, his temperature is 37.5 Celsius, heart rate is 118, respiratory rate is 20, and blood pressure is 152/83. So I also recommend highlighting all abnormal vital signs. And this patient is a little tachycardic, tachypneic, and slightly elevated blood pressure. He appears anxious and confused. He is oriented to person and place, but not to time. So he's alert and oriented to ×2, but not ×3. Pupils are 3 millimeters and reactive, which is normal. Remember, 3 millimeters for your pupils is totally normal. Neurologic exam is otherwise unremarkable. Respirations are mildly labored. No murmurs are auscultated. Radial pulses are strong and rapid. So they're rapid because he's tachycardic, and they're strong, which means they're not faint, which is good given the overall presentation. That's reassuring. And electrocardiogram reveals atrial tachycardia with 2:1 AV block. We'll come back to this. We'll talk more about it. So before we go on and look at the answer choices, let's take a moment to synthesize what we've read. For these really complicated question stems, these long, very long stems, I think it's really important to take a moment and look at the elements that you've highlighted, piece them together like you're piecing together pieces of a puzzle, and try to identify what the overarching picture is. What does the constellation of findings correspond to? What diagnosis or underlying condition or situation kind of emerges when you put these pieces together? So let's synthesize the key elements here to provide an example of what I mean. So what I mean by this is for these long stems, I actually recommend just jotting down a few bullet points of what the key differentiating findings were from the stem. So if I were to do that for this stem, I would kind of pull apart findings in 3 different systems. First, I would say there are some neurologic findings. And I would say that the confusion, both symptomatically but also objectively, right, because he's not oriented to time. So confusion or altered mental status, as well as weakness, although this could be nonspecific. It does generally fall into this category. And then the visual disturbances, especially the color changes. Okay, the next system of key findings here is going to be the GI system, right? So this patient has abdominal pain, nausea, and anorexia. There is this history of weight loss, although it's a pretty small amount of weight loss, and that could be there just as a distractor. And then thirdly, the last system of findings is going to be the cardiovascular system. And here we have tachycardia, and we have these EKG findings. Now, when you're doing this, when you're answering the question by yourself, I don't think you need to write down every single thing I wrote down here, but I'm doing this for illustrative purposes to kind of highlight what I mean by pulling apart these key findings from the question stem, that when you look at it this way, it's a lot easier to dissect. It's a lot easier to synthesize what all of these findings, what this constellation of findings corresponds to. So do you remember what this constellation of findings corresponds to? So this is a classic description of digoxin toxicity. And although you could have any combination of neurologic, GI, and cardiovascular findings, there are a few very specific findings that could really clue you in if you were unsure about this, that were clues to the fact that this was digoxin toxicity specifically. So the first one is the color changes, the yellow discoloration of objects. These color changes are very classic for digoxin toxicity. And then these EKG changes, the atrial tachycardia with 2-to-1 AV block, specifically just atrial tachycardia, doesn't have to be 2-to-1, just any type of AV block. Atrial tachy plus AV block is very specific to digoxin toxicity as well. So this is a hard question because it's kind of, you either know what this toxidrome looks like or you don't. And if you don't, it's a very confusing picture because it includes multiple different systems. But if you do, it's a slam dunk. So after reviewing this video, I hope that you're able to recognize this constellation of findings if it appears on your exams afterwards. So constellation of neuro, GI, and cardiovascular findings with some of these very specific findings that I mentioned. So I do want to point out a few things that are important. Let's start by reviewing digoxin toxicity in a bit more detail, and then we'll come back to the stem. So digoxin toxicity, as I mentioned, presents with a combination of cardiovascular, neurologic, and GI findings. And so let's point out a few important ones here. So it can present with palpitations, syncope, presyncope, dyspnea, which our patient did have, and really the life-threatening aspect of this toxicity is going to be the conduction abnormalities, the arrhythmias. And the very specific finding for digoxin toxicity, although it can present with any number of conduction abnormalities, is going to be atrial tachycardia with AV block. You don't need to be able to recognize what that looks like on EKG. I would just know that, and this is definitely a higher level point, but I would just know that when you see this specific EKG finding, it should make you think of digoxin toxicity. You can also just get a lot of PVCs or other conduction abnormalities, but this is very specific for digoxin toxicity. You can also get GI symptoms, and these are non-specific, so it's going to be more just the presence of GI symptoms in general. Anorexia, nausea, vomiting, abdominal pain, and then neurologic findings. Again, some non-specific findings like fatigue, confusion, weakness, and then it's going to be these vision changes that are more specific. So alterations in color vision, most classically where objects appear yellow. And then you might also get scotomas, blurry vision, or blindness. So the constellation of these three systems with some of these very specific findings, like the color changes and the AV or atrial tachycardia with AV block, should clue you in to digoxin toxicity. And this is a very classic toxidrome, and it's high yield and it's commonly tested. A few things that are also higher level points, but I think are really important to know about are going to be the presence of the precipitating factors. And these were actually present in the question stem and were also really important clues. So certain antiarrhythmics, specifically amiodarone, although it could also be verapamil, quinidine, and propafenone, can increase your digoxin levels. And so when patients start these antiarrhythmics, digoxin levels actually need to be decreased by about 25 to 30% because these antiarrhythmics increase your digoxin levels. So if those titrations are not correctly made, it can precipitate digoxin toxicity. And another major risk factor is going to be the presence of hypokalemia, specifically in this can be seen in patients are on loop diuretics where they have hypokalemia. That can actually increase patient susceptibility to toxic effects. So either both of these in combination or just one of the two can be precipitating factors, especially when new medications are added on. That's always a red flag for me when the question stem mentions that a medication was recently added. That's like a light bulb going off in my head that it might be a pharmacology question, or that the question may be asking me to really hone in on what this medication change precipitated. So pay attention to that when you see that in the question stem. Recently started on this or that medication. So let's go back to our question. And I want to point out here that this patient was already on digoxin and amiodarone was recently started. So this to me was a red flag, like I said, that this might be a pharmacology question. And again, these long lists of questions are also clues that this might be related to pharmacology. And the patient was also on furosemide already, so he already had the possible hypokalemia as a precipitating factor. So he had multiple reasons to be susceptible to digoxin toxicity. So let's look at the other answer choices and see why some of them were wrong. So DKA was wrong because although in an elderly gentleman with altered mental status and GI symptoms, you certainly could think of DKA, but without any mention of diabetes in the history or any mention of elevated glucose levels or ketones or a fruity odor on the breath. Although you could think about that with the labored breathing and the GI symptoms and the altered mental status, there's just not enough there to make you think that this is DKA, because they would have to give you something else to clue you in. So that's wrong. Amiodarone toxicity. Now, this is tricky because we know that amiodarone itself has a pretty comprehensive and complex toxidrome itself, with some neurologic findings, some endocrine findings, GI findings, also some eye findings. So that was there as a distractor, because if you didn't remember the specifics about amiodarone and digoxin toxicity, you might not have been able to tease these two apart because the patient was on both of them, and both of them have a very complex constellation of findings for their toxidrome. So this one really relied on your specific knowledge of the amiodarone toxicity and digoxin toxicity. And although we don't have time to review it here, if you don't remember the amiodarone toxicity findings, now's a great time to review them, because this is also very highly tested and high yield. So definitely make sure you know all the findings that are part of the amiodarone side effects and toxicities. But in this case, it was wrong. Brain metastasis. So this was there as a distractor because this patient had lost 4 pounds, which really isn't all that much in an elderly gentleman with a lot of comorbidities, but it was there to distract you because he also had neurologic findings. and some GI symptoms, so maybe concerning for increased ICP. But again, this is a primary brain lesion, and you would not expect the cardiovascular abnormalities that this patient has. Viral encephalitis, similarly, this could present with acute onset, altered mental status, some fatigue, weakness, confusion, but it wouldn't have the additional GI findings and cardiovascular findings. So there are too many other things here that don't fit with the primary neurologic process. So we can cross that one off. Brainstem stroke, again, this was a distractor because you might have seen the patient had AFib, and so you might have already been thinking, oh, AFib, he's susceptible to strokes. However, again, there are too many other findings here beyond just neurologic findings. And this was a distractor because of the vision disturbances, the confusion, and the susceptibility to strokes because of AFib, but again, doesn't fit the constellation of findings including GI and cardiovascular findings. Digoxin toxicity, so we identified that this was the correct answer. G, hypertensive encephalopathy. This was also supposed to be a distractor because this patient did have elevated blood pressure and had a history of hypertension. However, you would not expect the other findings in the GI system and the cardiovascular system. And this blood pressure, although elevated, is not so high that we would expect to see hypertensive encephalopathy. There was also no mention of headache. So again, it didn't quite fit, although it was there to distract you. And then finally, heart failure exacerbation because of some of the vital sign abnormalities, the labored breathing, and the weight loss. Potentially could have been concerning for worsening of his heart failure. However, there's not enough there. There's no lower extremity edema. There were no crackles on exam. And we had more than just the cardiovascular findings. We also had the neurologic and GI symptoms. So that was incorrect. So a lot of these were distractors that if you didn't know what the toxidrome was for digoxin, could have all sounded correct in some way, but none of them fit the constellation of findings perfectly. So this was one of those questions where you either knew the right answer or you didn't, but after reviewing this video, I'm confident that you'll be able to recognize digoxin toxicity in any question that you encounter. So thanks so much for listening, and that wraps up our question of the week.